So John is a 73-year-old male diagnosed with non-small cell lung cancer. You see John at the hospital over the weekend. He presents via an ambulance. He's confused, disorientated, diaphoretic. And then again, you can see that there's 3 different questions. And the first one is 4 minutes, second is 3 minutes, third is 3 minutes also. So you have your time to prepare, and then the first question comes up, and the question is outline your differentials, investigations, and management. So again, overarching statement or overall impression is that this patient is quite unwell, and there's a wide differential that should be considered for this presentation. He's obviously had a deterioration of his clinical state. We've got to consider differentials including metastases involving the brain. Has he potentially had a TIA or a stroke? Is there an infective cause like a urinary tract infection, pneumonia, sepsis or unknown source? Is he delirious? Is there an onset of Alzheimer's? Or is there any electrolyte imbalances in particular that can happen with cancer, mostly calcium imbalances, which can cause this kind of presentation. So with regards to what I would like to do, I'd like to get a current set of vital signs on this patient. If I have a chart for him, I'd like to see if there's any ARP in the chart or if there's any advanced health directive. If I can ask him questions and find out that information. Otherwise, if there's any family members that I can get that information from, that would be very helpful. I'd like to work in a systematic approach, so using my doctor's ABCDE approach again. So yeah, looking for any signs of danger to myself, to the patient, and the staff. Checking for the patient's response. Is he actually able to speak to me? Is he verbally or physically aggressive? Do we just need to be mindful of that with regards to safety for everyone involved? So sending for help, I'd like to get a couple of nurses help me with regards to getting some vital signs off this gentleman, and if I can have another doctor to assist me, that would be helpful. I'd assess his airway, breathing, circulation. With regards to a couple of investigations that I would like to do, I'd be looking at doing a urine dip and sending it off for a culture as well and a sensitivity. I understand that I'm not going to be getting that result back for a few days. I'd want to take some bloods from this patient so I can do some eye stats currently to get some results with regards to his pH, his electrolytes, the lactate, and I'll send some formal bloods away as well. Again, being mindful I'm in StAMPSville, I'm not going to get those results for a couple of days. I'd like to call in my radiographer and do a chest x-ray to consider is it a pneumonia, any chest source of infection, and I don't have access to a CT in my StAMPSville, but I'd be considering, does this patient need a CT of his brain? Do I need to consider metastases? And if that's the case, obviously he does need to be transferred for this, but keeping in mind what is the ceiling of care? Does he have any wishes? Does he just want to be kept comfortable? And how far is the family willing to want things investigated, and how invasive of procedures do they want? Then management, I'd be looking at treating the symptoms, making sure that any pain that he has been managed, and looking at, with regards to his long-term management, linking him in with the palliative care team, community health nurses, and any support networks in that respect. I'd also like to discuss his end-of-life cares, his ARP, both with the patient and the family, next of kin, and yeah, make sure that they are aware, and it has been discussed with regards to, pardon me, what to expect with regards to as the patient nears end of life. So one thing I did forget to mention, if you run out of time and the assessor moves you on, that's okay. Just go with the flow. So question 2, John comes back from the regional hospital after having a CT brain, which shows numerous metastases. Outline your approach to this discussion. So essentially this will be about breaking bad news. Having a support person present would be quite helpful. The information that you're going to give them, they're probably not going to retain most of it, so the support person is going to be quite vital in this case. Discussing that the case is terminal and what kind of management may be done for him with regards to radiotherapy to help shrink the mets, or is it viable to do surgery? Discussion of using dexamethasone for again shrinking the size and also helping reduce nausea, vomiting, improving appetite, symptomatic management, and talking about considering advanced health directives if it's not already been done, enduring power of attorneys, ARP's end of life planning definitely needs to be discussed, where the patient would like to die, if they've got any plans, and what their wishes are, and having that family group discussion I think is quite important, so everyone's had the opportunity to raise their concerns. And also having an assessment from the speech therapist, which you have available in your StAMPS fill, with regards to aspiration risk, what he can and can't have. Does he need thickened fluids? Would be important. So the third question for this case, John's wishes are to be comfortable and die at home. You saw him last week during another admission to hospital. He had deteriorated. He was in pain but was able to swallow. His wife, Janice, has presented to the GP practice and asks you for a script for his hydromorphone tablets. She looks a little frazzled. How do you proceed? So this one's about, I guess, exploring the mental health of the carer or the wife, discussing carer stress and finding out, you know, how is she doing? How is she holding up in this stressful situation? Does she have any support networks? And what is she doing for her own mental health and sanity? Discussing respite care that's available to assist with the carer stress, and Meals on Wheels if you have that available in your StAMPS field. Most small communities do have a form of Meals on Wheels, and ensuring that the wife's having her own mental health attended to. Take this opportunity to have a chat to her about her own health. Discussing John's pain, how bad is it at the moment, how much breakthrough therapy is he using, how is he going with the hydromorphone, is there any side effects, offering to do a home visit, which most rural GP practices do, and getting the PAL care nurses involved if they've not already been involved, making that link between the services and the patient and their family is important. Talking about the expectations of end-of-life care, and giving written information to the wife, because she's not going to be able to retain much of the information you've verbally given her if she's a bit frazzled and just not in a great state of mind herself. And with regards to her mental health, I guess exploring, you know, what her risk assessment is. Does she have any risk of self-harm, suicide, homicide? And yeah, giving her a bit more information with regards to when it becomes towards end of life, the use of a syringe driver, and how the community nurses can help in relation to that. Just making sure that they're aware of the kind of things that medications can help to be can use for, like the death rattle, which is most distressing for the family and the people watching rather than the patient itself. So yeah, they're just